Thank you very much, and thank to the speakers that kept on time beautifully. We still have about 15 minutes Q&A, questions and answer session. So I would like to invite all the speakers to the podium. And before I open for questions, I'd like to thank Francisco Garcia for chairing this very interesting session, and Eduardo Franco and Mona Saraya for putting together this very interesting public health workshop. So now the presentations are open for questions, and I guess I can say that you can address it in English and Spanish. I think we can help everyone to have their questions answered. Please go ahead.
Hola.
Hola.
I can't speak anymore, but my question to you is leverage for María. I thought that was really interesting about the call centers and thinking about leveraging call centers in low and middle income countries. Have you had any discussions? Because there might be an opportunity to use those call centers for local use as opposed to the international support. I was just wondering if you've had any discussions with low and middle income countries, especially in Asia where there's a lot of call centers.
Yeah.
Yes.
We actually haven't, and as a matter of fact, I looked a little bit into call services in preparation of this presentation because I wanted to say, oh, you know, in this country, they have these services, and it was really difficult to find. There are lots of telephone service hotlines for things like suicide prevention and things like that, domestic violence, but call services that are specifically designed to provide social services per se, like 211, I didn't see any other models in a quick search. Others may know more. Nevertheless, I think that even those types of services are typically reaching people who are low income and in need of cancer control and vaccination. So I think that there is an opportunity to do that. I also think that when other countries see the cost, sort of the cost benefit, the budget impact of systems like this, it may be something to consider as they're trying to reach these populations.
Thank you. Additional questions, comments? Yes.
Okay,
please.
María,
Yes.
I have a question. Could you talk a little bit more about how the recruitment process worked with the 211?
Sure. So we're doing a study, and so we set it up so that people are randomly asked to participate. Right. The eligibility is anyone who's over 18. And not in a crisis. So there are individuals that call that are in a complete crisis, and we don't even ask them if they'll answer a few questions about cancer risk. But if they're not, we ask them if they're, so we have several people trained to administer what we call this risk assessment survey. They answer, and they ask the caller if they're willing to answer a few quick questions. The caller agrees, and then once we identify this is an individual in need of a Pap test, is an individual in need of HPV, or has a daughter that needs the HPV vaccine, then we'll automatically make that referral. For some individuals, they will be transferred to a patient navigator. So this study was funded by the Cancer Prevention Research Institute of Texas, and so we wanted to provide services to as many people as we could. So it's not a 1-to-1 ratio, it's a 3-to-1 ratio. So 3 out of every 4 callers are being referred to the navigation, and then 1 to our comparison arm, which is connection only.
And one last question, I'm sorry. Sure. Are the 211 centers managed by the same body nationally, or United Way, or?
There is, United Way plays a very heavy role in the management and funding of 211 call centers, but they don't all have United Way support. So for example, in our study, the Weslaco site is not supported by the United Way, but the United Way does support many of the 187 call centers around the country. There is a national sort of broad, I would say, umbrella organization, but they're each managed individually. They all, typically in a state, they all have access to similar databases in that state.
Okay, thank you.
Yes, please.
I had a question for Groesbeck. Thank you so much, actually, for your very candid presentation. I appreciated the honesty. My question is, what about this breast cancer leveraging and introducing breast cancer screening? How is that working? What kind of method is being promoted,
Right.
and the evidence behind that? And then two, how do you, I mean, is it true that the indicator is going to be decreasing mortality related to breast cancer?
Right. So what we have done with breast cancer is to start out by training all of our cervical cancer prevention nurses how to perform clinical breast examinations. The country does not have the capacity for mammography, even though there are analog mammography machines placed throughout all of the provinces. They don't have the radiologists, they don't have the technicians to read the films, et cetera. There is some evidence that clinical breast exams can result in the downstaging of breast cancer. Whether that can be translated into decreasing mortality rates in our environment, we don't really know yet. We do know that this whole thing of self-breast exam in women in 2 studies in China and Russia did not translate into mortality rates, but that type of work has never been done in an African population. Studies have never been done using clinical breast exams versus nothing in an African population. So those areas are open for research, but it seems like there is some evidence that it can downstage breast cancers, and the assumption is that if a woman comes in with earlier stage disease, there's a possibility it may translate into prolonged survival. So with this $200,000 grant from Komen, what we are trying to do is to see if we can develop a model for breast cancer screening, diagnosis, and treatment. So all of the cervical cancer prevention nurses will learn how to do clinical breast exam. The goal is to also teach them how to do ultrasound-guided core breast biopsies on palpable masses. We are not approaching women who are asymptomatic. That's somewhere down the road. So women who come in and they come in saying they felt a mass, and it can be confirmed by the nurse, or the nurse feels a mass, she will be trained how to perform an ultrasound-guided core biopsy. That's the best piece of type of tissue to get for an analysis. The pathologist will be also trained with this money, and we will also train a small core group of surgeons how to perform lumpectomy and sentinel node biopsy, not using radiographic material, but using methylene blue dye. So we are getting a surgical oncologist, a pathologist, and a gynecologic oncologist from the University of North Carolina who will come to Zambia and train a core group of people, and they will monitor it and see if that turns out to be a workable, scalable model. We don't know.
Very interesting. Yes, we have a question there. Please.
Yuning Chao from Beijing, China again. And I have a question for the Nathalie. And you talk about the STI prevention and the cervical cancer programs. And in China, we try to integrate our STI prevention with cervical cancer prevention. But we have difficulty to convince the government. Even we put the budget into our cervical cancer prevention screening program, but we cannot say to the government. It's the same situation in another country because you have experience to, worldwide. How can you deal with this kind of dilemma? We want to do health professionals, but the government, they don't think the STI is the government responsibility.
Well, it's not an easy question, but it's true. But China also has a particular model of health system which is quite compartmentalized. So it's difficult, for instance, in China, what would be maybe feasible, that would be to work with maternal and healthcare services, where you can integrate much more intervention with regard to STI control, and maybe provide counseling to women and postpartum to come and cervical cancer screening later. It will be certainly more difficult with the STI services, I agree. So in other countries, for instance, the experience we had in Kenya, Nigeria, and Ethiopia, that was the package of intervention I was showing in reproductive health services, where they provide family planning, where we integrated STI services. And so now on top of that, you need to integrate cervical cancer screening. So it's a question on how you offer your services and how you can organize that in the most adequate way. And it's very country dependent. But in China, there was some success, I think, in terms of integration of cervical cancer screening into the family planning services.
Right. We use the healthcare and the system just for women and children health centers. That is the main workforce for the women health and the cervical cancer prevention. Thank you.
Thanks, Elaine.
Apropos of that last question, one of the real challenges, I think, is that, especially in Asia and Latin America, where non-communicable chronic disease is becoming a bigger and bigger sort of public health burden. You did a good job of talking about how to integrate it into the adolescent framework. How do you see that being integrated into the chronic disease framework?
Okay, I think that the most easiest, it's not easy, but feasible intervention to be integrated in the adolescent health framework is really things related to health education. And that's why we need to build on the existing system, either school-based intervention, or the school health system, or either, there's some programs looking on how to reach adolescents. And it's really, that's all the things about physical activities, nutrition, smoking, alcohol consuming, safe sex. So that's all a sort of package within the NCD context. And I suppose that at the moment, really, we need to work a lot on health education. That's really what we need to think about. Yeah.
Thank you. Additional questions or comments? Or I guess, yes? Francisco, I guess it's time then to close this session and to thank very much the speakers and the audience for this very interesting session. And merci. Thank you. Thank you.